Hello everyone, good evening and welcome to MEDVERSE. Today we are going to do that chapter of cardiology that is mitral stenosis, considered a bit tough to understand. As we saw from our previous videos on cardiology, first we did was aortic stenosis, then aortic regurgitation, and today we are looking at an entirely different entity, you can say, that is mitral stenosis, right? After mitral stenosis, we'll move on to mitral regurgitation or as the situation demands. Done? Okay. Remember, in cardiology, concepts are very important. So please don't mug up and try to go by concepts. If you have any confusions, you can text me. And starting with mitral stenosis, look, first we have to understand the morphology of the mitral valve, right? The mitral valve is a very important structure which is there, and basically it has an annulus, right? It has an annulus having an anterior annulus and a posterior annulus, right? So we have a fibrous ring present. So we have something called as fibrous ring present, this type of structure. Okay, this is called anterior part of annulus and posterior part. This is anterior annulus and this is posterior annulus. This morphology is important. We'll look at, okay, anterior annulus and posterior annulus. Okay, we have two leaflets as well. One is which is going down like this. I can't draw in 3D, but if you see, we have a leaflet that is going down from the anterior side. That is called as the anterior leaflet. And we have a short one. Okay, we have a short one having three lobes. That is a posterior leaflet. So you have something like this. I can't draw in 3D, but you have to imagine that anterior leaflet is like that, posterior leaflet is like that. Because the leaflets are the cusps by which they are closing, right? So we have something called posterior leaflet. So anterior leaflet and posterior leaflet, right? So these are attached to the annulus. Okay, these are attached to the annulus, and we have, you know, that we have some fibers like this. We have some fibers like this. Okay, and these fibers are attached to some muscles. I'm sure you must be knowing this. These fibers which are present are called as chordae tendineae. Chordae tendineae. Okay, chordae tendineae are attached to muscles. So let's draw it like this. These are muscular structures, and these are called as papillary muscles. Papillary muscles. Okay, chordae tendineae and papillary muscles. So papillary muscles are basically you can see we have a lateral papillary muscle and a medial papillary muscle. Okay, so this is the lateral one, this is the medial one. Lateral papillary muscle and medial papillary muscle attached to chordae tendineae. Chordae tendineae in turn are attached to the leaflets. We have two leaflets, anterior leaflet and posterior leaflet. Then anterior and posterior leaflet are attached to the annulus. This whole part, this white part is the annulus. So we have anterior annulus part and a posterior annulus part. Okay, and we have two commissures here. Two commissures are basically the end parts. Okay, so we have a fold like this part which I'm shading in pink. We have a anterior or anterior medial commissure or posterior lateral commissure. So here in anterior and a bit medially, okay, we have the anterior medial commissure. Anterior medial commissure, and here we have a posterior lateral commissure. Anterior medial commissure and a posterior lateral commissure. Okay, and mitral valve has very importantly, some authors write that mitral valve, the left ventricular myocardium is also considered to be a part of mitral valve. So we have, along with it, we have the plus left ventricular myocardium. We have the left ventricular myocardium, which is a part of mitral valve. So here we saw the morphology of this mitral valve. Now we'll move to some of the etiological factors. We'll look at the classifications and the etiologies of this mitral stenosis. Okay, so we're starting with it. The bits I have added is straight away is a compilation of this textbook, which is the 21st edition of Harrison's, right? So 22nd edition is there, but in this chapter there are no updates as such, right? So I'm keeping it simple and using the 21st edition as my main reference. Okay, but I will quote some other things from other textbooks as well. Okay, so 21st edition is there, so we'll look at it along with simultaneously. So if I talk about etiology and pathology, Harrison has to tell that rheumatic fever is the most common cause. Rheumatic fever is the most common cause. This is a very important term. Predominantly, it is associated with rheumatic heart disease. Okay, rheumatic heart disease is the most common cause. Okay, so rheumatic fever associated with valvulitis. Okay, it's the most common developmental thing which is relating to it. So acute rheumatic fever plus will have a valvulitis associated with some thing like mitral regurgitation sort of thing. Okay, it can lead to MS plus MR combinations. MS plus MR, we can have MS plus AR plus AS. This type of combinations may be possible, right? So these are the things. The commonest one is the combination, that is MR plus MS. The most common combination associated with rheumatic fever is MR plus MS. Okay, this is the most common combination. You can have MS plus AR or AR plus AS. Okay, this type of thing is there. But what happens in the pathology, if I talk about the pathology, we'll move to this later because this is a hemodynamic things we'll discuss in a flow, right? If I discuss it now, then it won't make much sense. Let's see here. Okay, so I told you that we have in mitral stenosis, we have the fusion of commissures. This commissures which I drew, we have in pink, let us maintain the color code as well. There is a fusion of commissures. There is a fusion of commissures. So this anterior medial and this posterior lateral commissures are basically fusing. As it has a rheumatic pathology, we can have calcification on the top of that. Okay, we can have calcification as well. So calcification. Look at this. The commissures are basically making this valve like this. Agreed? The commissures are making this valve like this. Not like this specifically, like this. If they are fused from the ends, let's say they are fused from here and here, they're fused from here and here. So what kind of appearance are they making? Are you able to remind of that fish with that flat mouth? So we have a classical fish mouth appearance associated with classical fish mouth appearance, which is associated with it. Classical fish mouth deformity or fish mouth appearance is associated with it. So commissure fusion is the thing. So what will be the treatment? Just guess. We don't do valvotomy here. We'll do commissurotomy. Okay. So we have to remove the commissures as well. Okay. So commissurotomy is the treatment of choice in this condition. Okay. Treatment of choice in this condition. But if there is calcification, will you do commissurotomy? In calcified cases, commissurotomy is not preferred. Okay, so this is the thing. So calcification, I told you, can be associated with this. With this calcification, the valve leaflet are basically immobilized. Okay, immobilization of leaflets. Now they can't move like this. Okay, so there is a increased stenosis. There is a stenosis. Remember, whenever there is stenosis, there is stasis. Just remember very importantly that it is associated with a thromboembolic phenomena. Okay. So thromboembolic phenomena, this condition, this stenosis, basically predisposes the heart to thrombosis. Okay. So this will predisposes to stenosis, thrombosis. Okay. thrombosis. And this is our main concern in this condition. In mitral stenosis, the thromboembolic phenomena, that is the thrombosis, which can break off and become an you can say embolism can occur. Okay, this is our basically concern here. And the most common site, remember, the most common site in which this thrombosis can occur is the left atrial appendage. Okay, left atrial. Most common is a left atrial thrombus. This left atrial thrombus is the most common thrombus associated with it. And to see the left atrial thrombus, you can use here, look at this. Harrison's write that in investigations to see the left atrial thrombus, will use the echo. TTE or TEE. We'll look at this. Don't worry. We'll look at this. Transesophageal and this transthoracic echo. Okay. So this type of conditions are there. Left atrial thrombus, I told you. Okay. In this condition, this if there is a thrombosis, then obviously you won't do commissurotomy. Obviously, you won't do commissurotomy. Okay, you want to do. Okay. According, we saw this is the pathogenesis. You can write this pathogenesis. I told you about fish mouth appearance, which is a classical feature seen in mitral stenosis. Okay, we'll see the classification. We'll see the classification. Look, mitral stenosis can be divided into three types. The old classification was a different sort of entity. The new classification is dividing mitral stenosis into three types based on the mitral valve area. Okay, this mitral valve area is taken into consideration and it is divided into three types. The three types are progressive. In this progressive type of mitral stenosis, the valve area is more than 1.5 centimeters square. The mitral valve area is more than 1.5 centimeters square. The treatment algorithm will be based on this. You can look at this in the Harrison's. The treatment algorithm, I have simplified it. So it will be based on this area. It will be based on this area. Okay. So progressive, more than 1.5 centimeters square. We can have a severe form and a very severe form. Severe form, progressive MS, severe MS, and a very severe MS. And a very severe MS. So progressive is more than 1.5 centimeters squares. This severe form may be symptomatic, asymptomatic, doesn't matter, is less than 1.5 centimeters square. Okay. And this very severe is less than 1 centimeter square. Less than 1 centimeter square. So this is very, very important. You have to understand the classification. Okay. So this is the thing which you have to classically understand. Okay. So now let's look at the cardiac events in the MS, which are very important. And this is what we for cardiac events, right? So let's shift this to here. We'll look at this whenever. Okay. If I talk about other causes, congenital, it can be congenital MS. It can be cor triatrium. It can be severe mitral annular calcification. I told you it may be associated with a calcification, right? It can be associated with systemic conditions like SLE, right atrium. Sorry, rheumatoid arthritis, not right. Left atrial myxoma. Okay, it can be associated with atrial tumors like left atrial myxomas. Okay, infective endocarditis with vegetations. With vegetations. So this is what Harrison writes of the causes of mitral stenosis. So if you have a theory exam, just enumerate all these causes and you're ready to go. So pathology, I told you. Pathology, I already told you. We have something called chronic inflammation, leaflet thickening, commissural effusion, and calcification. And this condition is called as the fish mouth valve. Okay. So I told you already about the fish mouth valve. And now we are ready to go into the cardiac events. cardiac events of MS, which is our main part of discussion. Look, very importantly, understand that this mitral stenosis is a diastolic dysfunction. The first, foremost, and the most important line here is to understand that it is a diastolic dysfunction. What happens in a diastole? In a diastole, basically, we have our S2, second heart sound. Okay, if you visualize the cardiac cycle in your head, diastole first S2 will occur. S2 in this, there will be closure of this valves, aortic valve, pulmonary valve. This will close. Okay, then there is a phase of isovolumetric relaxation. Okay, then the phase there will be isovolumetric relaxation. In the phase of isovolumetric relaxation, at the end part, terminal part of isovolumetric relaxation, this mitral valve will open. Okay, this mitral valve will open. This mitral valve basically opens completely, so we have a no pressure gradient at all. Remember I told you about the aortic stenosis, and I am talking about mitral stenosis in the same way. In aortic stenosis, remember, if you haven't watched, please do watch aortic stenosis before coming to this lecture, because I will be using the terms along with it, right? Okay, in aortic stenosis I told you that this was our aorta, and this was our part of left ventricle. And I told you there is a common channel here. In the aortic valve was opening completely. The aortic valve was opening completely. So there is the pressure gradient. There is a common channel. So I told you that this delta P will be basically 0. So if there is no delta P, nothing. Valve is working fine, everything fine, heart is working very fine. Okay. But I told you, whenever there is a transvalvular pressure gradient that is developed, this is our enemy, this is our problem. This transvalvular pressure gradient is our enemy, and this is our problem. This will cause the stenosis. Okay, so this is the opening problem. In previous lecture, we talked about aortic regurgitation. Aortic regurgitation was a closing issue. It was not closing completely, due to which blood was leaking down. Okay, and was filling with blood. This is a opening issue. Okay, the valve is not opening completely. So at the end of isovolumetric relaxation, mitral valve doesn't open completely. Mitral valve doesn't open completely. If this mitral valve doesn't open completely, then we have a pressure gradient which is developed. There is a delta P which is developed. There is a delta P, which is a pressure gradient is developed, and this, if there is no pressure gradient if the valve was opening completely. So if there is a delta P here, okay, and this delta P is basically increasing. Delta P will increase what volume? I discussed this pathogenesis at least 5 to 6 times. Whenever there is a delta P, there is a transvalvular pressure gradient. There is a transvalvular pressure gradient. Then it will increase the LVEDP. LVEDP is the left ventricular and diastolic pressure. It will increase the LVEDP. If the left ventricular and diastolic pressure increases, there will be an increase in left atrial pressure. And remember, whenever there is an increase in left atrial pressure, it will in turn reflect in the pulmonary capillaries, and it will increase the pulmonary capillary venous pressure or pulmonary capillary wedge pressure. Whenever there is an increase in pulmonary capillary wedge pressure, you have symptoms like dyspnea. So what is the pathogenesis of dyspnea here? Is basically this one. This is the pathogenesis of dyspnea. Okay, very clear, very clear. Okay. So we have the conditions which is occurring. Conditions are occurring at the end of this isovolumetric relaxation. Okay, this is the thing. Okay, so I told you that this is our classification: progressive and severe and very severe. Okay, basically, dyspnea is the you can see varieties of dyspnea here. Okay, you can have orthopnea, right? You can have orthopnea, patient stands up and having dyspnea. You can have pulmonary edema as well. You can have paroxysmal dyspnea. Okay, PND is a paroxysmal nocturnal dyspnea. This type of dyspneas are common. Okay, but here the classical feature is that dyspnea on exertion. On exertion. Why on exertion? This is the statement written in the questions on exertion. Why on the exertion? Because the patient is working fine. The patient is doing fine. When does the patient comes to your OPD? The patient will come to the OPD when he is having some kind of stress in his body. Some kind of stress, I mean, if he has an episode of exercise, if the patient is having fever, if the patient is pregnant, okay, if the patient is having something serious arrhythmic disorders like atrial fibrillation. So this conditions will occur when there is exertion. So exertion. Why exertion? Look, whenever there is stress, there is exercise, there is pregnancy, there is arrhythmic disorders, we have a condition called tachycardia, right? Our heart rate increases. This tachycardia, if the heart is pumping very at a faster rate, the diastole will shorten, and whenever the diastole is shortened, the filling time decreases, and whenever filling time decreases, the left atrial pressure increases. If the left atrial pressure will increase, it will in turn increase. The same thing will occur PCWP, that is pulmonary capillary wedge pressure. It will increase, and if this increase, then there will be dyspnea. So this dyspnea on exertion is a manifestation of mild or moderate MS. So in mild or moderate MS, this type of things occur because in mild or moderate MS, patient doesn't have much symptoms. Okay, the only symptom he usually comes with is dyspnea with exertion. Okay, you have to manage this. How will you manage this dyspnea with exertion? Basically, you give a beta blocker. Okay, beta blocker will this prevent this tachycardia. So management is just by beta blocker. You can give the cardioselective type of beta blocker, and the patient is fine. Okay, it will decrease the heart rate. Okay, so this we talked when the patient has mild or moderate MS. Okay, now let's talk if the patient has severe MS. Severe MS. Patient has severe MS. That means that the PCWP, that is the pulmonary capillary wedge pressure, is very very high. In this condition, in mild to moderate, the patient is fine. The patient is fine. There is no much, opening issue of this valve. It will occur. It will manifest once there is some kind of stress. But here already there is PCWP very very high. Okay, PCWP very very high. If this PCWP is very very high, then whenever there is a resist or a pressure in the smaller vessel, it will reflect in the larger vessel as well. Whenever there is a pressure in the smaller vessel, it will reflect in the larger vessel as well. Okay, so there is an increased pulmonary pulmonary artery and diastolic pressure. Pulmonary artery and diastolic pressure. Whenever there is an increase in pressure in the pulmonary artery, what we call this? What we call this? Pulmonary hypertension. Pulmonary hypertension. This pulmonary hypertension is the most important, you can say culprit, you can say factor, you can say anything, is the most important manifestation because it will present. This pulmonary hypertension can lead to this pulmonary hypertension can lead to as this is occurring in the right side, arterial part, right side. So right ventricular hypertrophy. This RVH can lead to failure. This pulmonary hypertension is will be responsible as there is more pressure. Okay, the closer will be very loud, and this loud closer, loud palpable P2, loud palpable P2 will be associated. There will be prominent pulsations. There will be prominent pulsations, and there will be in the pulse there will be prominent A and V wave. Prominent A and V wave. We'll talk when we'll pulse, so I'm not going to much details. Okay, and or we can have something called as the tricuspid regurgitation associated with it. We can have something called tricuspid regurgitation as well. Tricuspid regurgitation as well. Okay, so remember, so we have something, a funny thing where there is a, just a minute, let me make it cosmetically better. Okay, we have a thing which is called as a theory of second stenosis. So there is the stenosis within the stenosis. Stenosis within stenosis, or theory of second stenosis. What is this is telling is basically whenever you have a pulmonary hypertension, I told you there is a pulmonary hypertension. Whenever there is a pulmonary hypertension, there will be vasoconstriction, there will be decreased amount of blood which is entering, decreased blood into LA. Okay, the blood flow into the left atrium has decreased, but as there is a decreased LA, as there is decreased blood entering the LA, the patient will be feeling better. Okay, patient feels better. In the patient's view, patient is was sad and is going to happy. But in our view, what is the patient doing? The patient is progressing from mild or moderate MS to severe MS. Okay. Patient is progressing from mild to moderate MS to severe MS. But according to the patient is doing well. Okay. So this thing you have to understand very carefully, that if there is a relieving factor present over here, then it will be most likely progressing of the disease. Okay. Okay. Now, let's understand some other things. Okay, there is a power cut. Okay, so I was telling you, let's discuss some other things. I was telling you, okay, we are live. Okay, I was telling you that there is something called as ASOS, A2OS. Okay, there is something called A2OS. Okay, what is this A2OS? A2OS, A2. I'm sure you must be knowing about the hard sounds A2 and P2. Okay, A2OS is basically, this A2 means the closure. How will the A2 produced? Closure of all the valves like semilunar valve and aortic valve. Closure of semilunar and aortic valves. This is A2. OS is basically opening snap. Opening snap. Okay. AS is basically opening snap, and this opening snap is basically produced by mitral valve. When the mitral valve opens, it produces a opening snap. Okay. This just a minute, let me adjust the camera here. Okay. 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 Look, so I was telling A2OS, we have to understand this. Remember, in this condition, what is happening is that the left atrial pressure is very, very high. Okay. You are understanding that the left atrial pressure is very, very high. If the left atrial pressure is very high, just imagine if the left atrial pressure is very high. Okay. If the left atrial pressure is very high, then what will occur? There will be closing of this mitral valve very fast. Okay. Now, there will be opening of this mitral valve very fast. Okay, left atrial pressure is high, right? So mitral valve will open very fast. So since LA pressure is very, very, very high, this opening of mitral valve occur fast. Opening will occur fast and earlier. If opening occurs fast and earlier, what will happen to this duration from the closure of semilunar valve to opening? It will occur fast. So this duration basically decreases. So we say that the shortening is directly proportional to the severity of MS. If the MS is more severe, there is more LA pressure. If there is more LA pressure, more earlier it will be. Okay, more earlier it will be. So I am telling that this opening, you can say A2OS, A2OS is directly proportional to the severity. A2OS is directly proportional to the severity of MS. Okay, this is the thing. Okay, now let's go to another thing. Let's look at the symptoms which Harrison has to tell. Dyspnea, orthopnea, paroxysmal, let me write, paroxysmal nocturnal dyspnea, hemoptysis. We'll look at the cause of hemoptysis in a short while. Don't worry. Fatigue, palpitations. Since the left atrial pressure is high, the patient is predisposed to a dangerous condition which is atrial fibrillation. Atrial fibrillation. Recurrent pulmonary edema. We'll look at these conditions. Pulmonary edema, I told you earlier, right? Pulmonary edema. Here, it was a manifestation of this pulmonary hypertension. This pulmonary hypertension is basically manifesting as the pulmonary edema. Okay, here. Recurrent chest infections. Systemic embolism, I told you, which is the most common site. Left atrial thrombus. Left atrial thrombus. Okay, so these are the symptoms of aortic, not aortic, mitral stenosis. Okay, mitral stenosis. If I talk about murmur, let's talk about the murmur. Let's discuss a bit of murmur here. We'll have a separate discussion on murmur, I guess. Then we can just correlate the murmurs as such. But here you have to understand that the duration of murmur due to a gradient. Okay, this murmur is developing because of the gradient. Okay, where we saw that this is a gradient creation, right? Okay, so it will begin at the end of IVR, at start at end of IVR. Okay, it will start at the end of IVR due to incomplete closure of this MB. Okay, so if there is more LAP, there is more left atrial pressure, there will be more gradient. And if there is more gradient, then what will occur? The duration will increase. Increase duration of murmur. There will be increased duration of murmur. Okay, longer duration of murmur due to this more gradient. Murmur is there. Then we have to talk something called as pre-systolic accentuation. Pre-systolic accentuation. What is this pre-systolic accentuation? Remember, this phenomena is due to atrial contraction. Due to atrial contraction. Due to atrial contraction. Okay. So due to atrial contraction at the mid-diastolic period, the atrial contraction, this condition will occur, and this is absent in atrial fibrillation. Absent in AFib. Okay, this is absent in AV. Okay, this is the thing, and this is commonly associated with this murmur. This is commonly associated with this murmur. Okay, and another thing we have to know about the heart sounds. Let's talk about the heart sounds. Okay, murmur. Okay, we'll see at the signs after discussing about the heart sounds. So, what will happen to the S1? S1, what will happen? Of course. And if you see the position of S1, the position of the leaflet at the end of the diastole, it will open at the bottom. Okay. The position of the leaflet at the end, okay, it will be open at the bottom. If it is open at the bottom, it is having a larger distance. Having a larger distance. It as it has having a larger distance to transverse, it will close with more velocity. If it will close with more velocity, what will be the effect of S1? Of course, loud S1. It will take more time or less time? More time. Means it will be delayed or fast? Earlier delayed, delayed. So loud S1 and there is delayed closer. Loud S1 with delayed closer. This is the thing which you have to understand. Then another thing, loud P2. Loud P2. I told you what will be the opening snap heard? Yes, there will be opening snap. Which type of murmur? I told you that mid-diastolic murmur with pre-systolic accentuation. These are lines of Harrison, which I am telling. Okay, these are not from some hi-fi source, but these are lines of your Harrison. So loud S1, loud P2, and murmur where it is best heard at the apex in the left lateral position. It makes diastolic rumbling type of murmur. This type of murmur is heard in best at the apex in the left lateral position. Okay, this is the auscultation finding. And science will see something classical feature, that is malar flush. Malar flush due to low cardiac output and vasodilation. Okay, this is the thing. Okay, now let's look at the backward pressure effects. Okay, backward pressure. So we saw that this, look at this pulmonary hypertension. Okay, this pulmonary hypertension. The look at this. This pulmonary hypertension was an effect of forward pressure. This pulmonary capillary, pulmonary artery, pulmonary hypertension, all of this, tricuspid regurgitation, RVH failure, all of this. Okay, these are effects of forward pressure. We have a back pressure here. We have a back pressure here. So just you can look at this. Let me draw it like this. Let me draw the capillaries in green. Let me draw the capillaries in green. These are the, let's say these are the capillaries. We have pulmonary vein, the venules in the vein. We have pulmonary artery. Okay, so this pressure is increasing. If this pressure is increasing, we have two-way transmission, forward as well as back pressure. So back pressure will go via pulmonary vein artery. Okay, and this via forward pressure will go via pulmonary artery. Okay, because the pressure is transmitting it like that, right? And pulmonary vein will be having a backward pressure here. So let's change the direction. This forward pressure and this will be having a backward pressure. So this backward pressure is responsible for some effects. Due to backward pressure, we have some effects. What will be the effects due to backward pressure? RVH was the effect of forward pressure. Okay, due to backward pressure, the clinical feature, there will be PVH. This will lead to dyspnea. We all know this. Okay, there will be increased right atrial pressure. Right atrial pressure will increase. This increased right atrial pressure will manifest as increased prominent pulsations, that is JBP. Okay, prominent pulsation, that will be JBP. Okay, and there will be right heart failure symptoms as well. Right heart failure symptoms. What are the symptoms of right heart failure? Classical features like ascites, wasting, edema, ascites, edema, all of these features. Okay, so this thing you have to understand. Okay, now let's move on to a very classical feature that is called as hoarseness of voice, which is mentioned in your uh, narrations. Look at this. Look at this. Hoarseness, which is called as the Ortner's syndrome, due to left atrial enlargement compressing the recurrent laryngeal nerve. Recurrent laryngeal nerve. And look at this. I don't think it had been written from here, but we'll look at this. The manifestation. We'll look at two important manifestations here. We'll look at two important manifestations here. Basically, what is happening is that the left atrial pressure is more. If it is more, it will stretch and dilate the atria. Dilate the atria, right? If it is associated with atrial fibrillation, very dangerous, very fatal. Okay, but as the atria is dilating, the atria is bigger here. The atria is bigger here. It is compressing on the underlying structures. What are the underlying structures? Esophagus, recurrent laryngeal now. It will big atria will compress in the structures like esophagus and recurrent laryngeal nerve. Compression of the structures like esophagus. What will be the thing? What will be the you can say manifestation? Dysphagia, obviously. Dysphagia, dysphagia. Okay, and if it is compressing the recurrent laryngeal nerve is responsible for voice. Okay, it is supplying the which muscle? Cricothyroid. What is function? Tensor of the vocal cord. Okay, so the voice will be shut down. It's called hoarseness of voice. Hoarseness of voice. Hoarseness of voice associated with this is called as Ortner's syndrome. Okay, Ortner's syndrome. So this is the cause of Ortner's syndrome. It is mentioned in the Harrison's Ortner's syndrome. Atrial fibrillation, we told systemic embolism, left atrial thrombus can break and cause embolization. Left atrial clots can form left atrial clots. Left atrial clots will transverse and cause embolization throughout the body. If there is a clot in the left atria, the blood will be pumped, right? Okay, it will move to left ventricle, blood will be pumped. Okay, the left atrial clots can dislodge anywhere. It will cause embolism in systemically. It will cause a systemic embolism. Pulmonary hypertension, I told you. Right ventricular hypertrophy, RVH, we talked. Tricuspid regurgitation, we talked. Recurrent pulmonary infections due to the same condition. Sorry. Okay. Due to the same condition, recurrent pulmonary infections and hoarseness, we talked. So, this many are the complications of mitral stenosis. Now, okay. Now, another thing, I told you that we'll discuss hemoptysis, right? It was written somewhere here. Hemoptysis. What is the cause of hemoptysis in this condition? Okay, what is the condition? This hemoptysis. Why there is hemoptysis in mitral stenosis? Why there is hemoptysis in mitral stenosis? If there is a increased left atrial pressure, it will rupture the thin-walled pulmonary capillaries and the veins as well. It will rupture the thin-walled pulmonary veins if there is an increased LAP. If the left atrial pressure is very more, then it will rupture thin walled pulmonary veins, the bronchial veins, and this condition is called as pulmonary apoplexy. Pulmonary apoplexy. apoplexy, and there is a bleeding, and this bleeding is called as hemoptysis, that is a blood tends sputum. Okay, this is the thing. And here we can have other causes as well. We can have pulmonary edema. Pulmonary edema, I told you, if the pulmonary edema, this is the most important reason. This reason you have to understand. Hemoptysis in MS, this is the most important cause. You have to tell, not apoplexy. You have to tell pulmonary apoplexy is the most important reason. Other reasons like pulmonary edema can occur. This pulmonary edema can go and cause capillary rupture. Obvious thing. Anticoagulants are commonly prescribed in this MS patients. These anticoagulants may be responsible for hemoptysis. This you can say, if there's some sort of pulmonary infections which can rupture these vessels, then it can cause hemoptysis in MS. Okay, if you have a type of chronic bronchitis, then there will be sputum that will be filled with blood. Okay, blood tinged sputum. Okay, all of these things. Uh, Heart sounds all are done. Let's see what we left. Okay, loud S1, loud P2. Loud P2, you know the reason. Obviously, I talked to you about pulmonary hypertension, loud P2. What will happen to S1? Loud S1. What will happen to S2? S2 will be palpable, obviously. S2 will be palpable, and there will be wide split S2 here. Okay, so if I haven't written, but it was obvious, S2 will be wide split. Why? I told you, right? In previous lectures also, I told you that wide split S2 will be seen whenever there is a differential closure of valves. Okay, there'll be wide splitting. The P2 will be very loud, right? P2 will be, very loud P2, pulmonary due to pulmonary hypertension, and there will be opening snap as well associated with it. So wide split with opening snap. So if there is a different more difference between the A2 and the P2, then there is a wide split S2. So this is the wide split S2. S3 and S4, remember, won't be hard. If we are telling that if you had S3 and S4 in this type of patient, it will be a big blunder. S3 and S4 won't be hard at all. Because S3 and S4 are hard only when there is a non-stenosed valve. There is one condition. I told you about this condition, the dilated, non-compliant. I told you many times in previous lecture that whenever there is a non-stenosed valve, only there will be S3 and S4. Here we have a stenosed valve present, and if there is a stenosed valve present, S3 and S4 will be absent. What is the murmur? Murmur, I told you, start at the end of IVR, and which type of murmur? Mid diastolic rumbling murmur. Mid diastolic rumbling murmur, or you can tell. Just a minute. Okay, so there are some issues with this. Okay, so I told you that this is called as the mid diastolic MDM rumbling type of murmur. It will be, of course, the low pitch murmur, low pitch. Okay, low pitch murmur and mid diastolic murmur with pre systolic accentration, with pre-systolic accentration. This type of thing is called rumbling murmur, or you can write rough rumbling murmur. Will be very prominent at the left lateral position. Will be very prominent the left lateral position, and it will be best heard with best heard. You can add this best heard with bell of stethoscope. Best heard with the bell of the stethoscope at the end of expiration. With there'll be no radiation at all. Okay, if you have to describe this, you can just describe it like that. It will have no radiation. Okay, so these are the findings at thing. And okay, another thing is that you can hear some other murmurs as well in MS. Okay, these things are there, but you can hear some other murmurs. Let me look at some space to write. Okay, here, let us write here. You can hear a type of pan-systolic murmur here. Okay, pan-systolic murmur associated with TR. Or you can, if it is associated with TR, then you can have a pan-systolic murmur, which is called as the Caravello's sign. Caravello's sign. So we have something called as Caravello's sign. which is a pansystolic murmur. Pansystolic. Or you can hear a diastolic decrescendo murmur as well. Okay, a diastolic decrescendo murmur as well. The pressure is very, decreasing at a very high rate. So we'll have a decrescendo type of murmur. Okay, so diastolic decrescendo murmur. This is called as the Graham-Steele murmur. Graham's Steele murmur. Graham-Steele murmur, and this is a diastolic decrescendo. Diastolic decrescendo murmur. Okay. If it is associated with ARF, if it is associated, Caravellos or pansystolic murmur, if it is associated with tricuspid regurgitation, and this, if it is associated with PR, that is pulmonary regurgitation. Okay. So here, look at this: tricuspid regurgitation, pulmonary regurgitation. These all things are from Harrison, so don't worry. PR. So PR, which murmur I told you now, that is Caravellos sign. Caravellos sign. And PR, which one? Graham's Steele murmur. Graham-Steele. Okay. And if it is associated with acute rheumatic fever, if associated with acute rheumatic fever, ARF, you will hear a type of mid-diastolic murmur which is named Carey-Coombs murmur. Carey, Carey, okay. Coombs murmur. Carey-Coombs murmur. Okay. Carey-Coombs murmur. And if it is associated with atrial regurgitation, remember atrial regurgitation, I told you there also we have a classical Austin Flint murmur. Austin Flint murmur. Classical Austin Flint murmur will be heard. Okay. Austin Flint murmur is basically seen in AR. Okay. You can hear also. Basically, Austin Flint murmur, as if you talk about that, it is basically sinus, generally of sinus rhythm. Okay, this MS, this mitral stenosis murmur, you have atrial fibrillation related, but here in Austin Flint murmur, there is sinus rhythm murmur. Okay, it is a, you can say, S1 here. If you know the difference between MS and AR, it's very easy. Okay, you can hear in this in condition will hear S1. Mitral stenosis S1 will be obviously loud. Okay, but in AR, this might AR S1 is soft, right? In AR S1 is soft. Opening snap, in opening snap, which is in which condition it is present? MS obviously. But in atrial regurgitation, there will be this opening snap, no, absent. So if you know the difference between this MR and MS, you can very well make out there is association with AR1. Okay. I haven't taught ECG, but just know from a perspective that, let me see if there'll be a slot, then I'll teach ECG as well. ECG findings. ECG findings, there will be an increased P wave amplitude as there is a right atrial enlargement, there is increased P wave amplitude. Increased P wave amplitude. Okay. If there is a left atrial enlargement, there is something called the P mitral. Okay, P mitral due to left atrial enlargement. I'm writing left atrial enlargement. We have a P mitral. We have a in this condition we have an enhanced second hump. In this we have a bicuspid type of P wave, like this type of P wave. Okay, and we have an enhanced negative deflection in the lead V1 as well. We have an enhanced negative, and in here we have a bicuspid type of wave. Okay, P wave. Okay, this is the thing. And if I talk about this, let us see here. ECG P mitral, broad notched P wave, or by this type of look at this by notched, you can say, or broad notched P wave. Okay, RVH pulmonary hypertension, this time X-ray. X-ray, there will be straightening of left heart border. The left heart border will be straightened. The classical CXR finding in MS, but nobody does it now. Okay? Nobody does this X-ray now. Left atrial enlargement will be seen. There will be double density. Okay, there will be double density. There's a classical curly B lines. There is a classical curly B lines associated with this condition as well. Classical curly B line. And pulmonary congestion will be obviously seen because there is pulmonary edema and there will be congestion. We will see. Okay, so you can very well make out with CXR, but what is the diagnosis of choice? The investigation of choice is always echo. Okay, you always go for echo. Echo may be TTE or TEE. Basically, TTE is transthoracic echo, and this TEE is basically transesophageal. Transthoracic echo and transesophageal echo. Transesophageal echo is very well tolerated, very well done, because this will enable you to see left atrial clots which are there in below, right? You can't make out it transthoracic. You can't see that LA clots in transthoracic echo. Our main concern, I told you the earlier, is that we have to see the LA clots because these are dangerous. This LA clots can be very well visualized with transesophageal echo, so this is better. This is better, okay, to rule out LA clots. Transthoracic echo may be used to stage the MS. Okay, it may be used to see the presence, if there is MR associated with it or not. To see calcification, the transthoracic echo is good, but transesophageal to see the LA clots. Okay, to see the LA clots. And which tumor resembles this? Which tumor resembles this? I told you that this here atrial myxoma, somewhere it is written. Okay. Left atrial myxoma is basically a tumor which is resembling MS. So question is coming that tumor resembling MS is basically atrial myxoma. So atrial myxoma has a manifestation of this. Okay, as a manifestation of this. Okay. Now we'll move to some treatment aspects. Management algorithm according to Harrison's. We give anticoagulants to those with clots. Okay, with LA clots, we give indefinite warfarin. Just write here, indefinite warfarin. Indefinite warfarin to patients with LA clots. Patients with LA clots. Indefinite warfarin. Okay. There is no role of newer oral anticoagulants, okay, in MS. These are the guidelines which I'm telling. There is no such role of newer oral anticoagulants which are coming up, right? But we can have a very classical, very a treatment of choice, which I tell you. Okay, a treatment of choice. Here it is written. Yes, it is written. PBMB. Okay, PBMB. You can say PBMB or you can say PMBV. Anything you can say. PMBV. Okay. Percutaneous mitral balloon valvotomy. Percutaneous mitral balloon valvotomy. Okay. Percutaneous mitral balloon valvotomy. Or you can say percutaneous balloon mitral valvotomy. Same thing, just interchange of MNB. Okay. So this is the treatment of choice. This PMBV is the, or PBMV is the treatment of choice. I'm writing RXOC. This is the treatment of choice. It will be done in all patients, but if if there is some calcification present, if there is a regurgitation is predominant, or if there is some thrombus as well. Thrombus. You have to analyze. Then this is contraindicated. This is basically nothing but the balloon is inserted, and this mitral valve is the valve leaflets are basically separated so that it will be opening very goodly, right? You can say like that. It will be opening very nicely. Okay, so we are basically opening some stenosed mitral valves by inflating the balloon. The balloon will be inserted by the catheter and the septic, cannula, and it is inflated when you will put a guide wire and you'll inflate it, then it will be enlarged. Okay, mitral valvotomy is the treatment of choice. Okay, which condition? Severe symptomatic MS. If severe symptomatic MS, if there is mild MS, you just observe. If there is mild MS, that is mitral valve area more than 1.5 centimeter square, just observe. But if there is severe symptomatic MS, that is mitral valve area less than 1.5 centimeter square, okay, then you have to do PVMB. If pliable valve, no LA clot and MR less than 2, then you have to do MBV. Okay. If not suitable, you have to do surgery. Surgery can be an option if you don't have to do. Asymptomatic but severe MS. Asymptomatic but severe MS. If there is stress test abnormal, low vitamin stress test we do, but no much role in here. But it was a good amount of, it held a good amount of importance in aortic regurgitation. But you have to do PVMB. So you just remember that in according to Harrison, it is a bit complex, but you have to just understand that you do mitral valve, then replacement. You do mitral valve replacement in cases of calcific MS. Here in contraindications, calcification, regurgitation predominant, thrombus. In this condition, you do, when there is a contraindication to percutaneous balloon mitral valvotomy, then you do mitral valve replacement, MBR. MBR can be done. Okay, to mitral valve replacement, which is a surgical option. But if it is not contraindicated, in all patients we do PVMB. And before PVMB, every patient must be analyzed via TEE, that is transesophageal echo. Transesophageal echo is done, and this transesophageal echo is best for ruling out LA clots. Okay, LA clots. Prognosis: natural history, long latent period, then progressive dyspnea, AF, embolism, pulmonary hypertension. 10-year survival rate after symptoms: dyspnea 18%, pulmonary hypertension less than 3 years. Not much important. You can just ignore this slide. Okay, you can just ignore this slide because Harrison's, we don't have to follow each word line by line. Okay, hemodynamics, I told you earlier. This slide was left. Normal MVA is 4 to 6 centimeters square. Okay, symptoms appear when mitral valve area less than 2 centimeters square, severe when less than 1.5. Okay, I told you about all of this thing. More than 1.5, less than 1.5, less than 1, classification based things. So this pathogenesis is already covered. Left atrial pressure increases, pulmonary venous hypertension, pulmonary atrial hypertension, and right heart failure. Okay, RV failure, right ventricle failure. Reduced LV filling, so there will be low cardiac output. There's a low cardiac output state, so it is basically manifesting more on exertion. So I hope you understood this mitral stenosis in total. You understood mitral stenosis, you understood the pathogenesis, you understood everything about mitral stenosis. Even then, if you have any confusion, please feel free to DM me and ask your confusion as well and clear them out. Okay, this type of things are, these are like cardiology is like mathematics. You have to exercise your mind again and again in that particular fashion so as to get more of it, right? So with that, let's meet in a new chapter, in a new mood, in a new, somewhat we can say, okay, in new lecture. Okay, that's all. Thank you and good night.